Welcome back to Mayo Clinic Radio. I'm Dr. Tom Shives.
And I'm Tracy McCrae. Urinary incontinence, that is, the loss of bladder control, is a very common problem. It's inconvenient and often embarrassing and much more common in women.
Joining us to talk about the problem is the chair of the Division of Urogynecology at Mayo Clinic, Dr. Emanuel Trabuco. Dr. Trabuco, welcome to the program. Nice to have you.
Thanks for having me.
I think most of us know what a gynecologist is, a woman's doctor, but tell us about a urogynecology.
A urogynecologist is a relatively recent subspecialization in obstetrics and gynecology, in which we undergo an additional 3 years of training after obstetrics and gynecology to specialize in pelvic floor disorders, most commonly pelvic organ prolapse or a hernia of the pelvic floor, and urinary incontinence.
It must be complicated down there if you have to go 3 more years to learn how to do what you do.
I'm just really happy that there is now a subspecialty of urogynecology because it is quite common.
It is indeed, especially with baby boomers booming. Problems with the pelvic floor and incontinence, unfortunately, is something that is going to continue to grow.
While we were setting up today, you said if I had a dime for every time a woman said, first I had a baby and then I can't, and then that's why she's sitting there with you.
And it's the reason why I wanted to do this, because I see that so frequently. A woman that tells me that since the birth of my first baby or the birth of my second baby, I've had issues with urinary incontinence, but that's now 10, 15, 20, 25 years down the road. And that's the first time she's really seeking any kind of treatment for her condition. And I just think about all the things that she missed out by not having this looked at earlier, rather than waiting such a long time.
Not jumping on the trampoline for one of them.
Well, isn't it interesting that so having a baby must be a little bit hard on the pelvic floor, because women who have had C-sections, had their babies by C-sections, don't have nearly as much of a problem, right?
That is correct. In general, women who have had a delivery by C-section, and the key is they didn't experience labor before having her C-section, they tend to have lower rates of stress incontinence after delivery.
Okay, so being a woman, being pregnant and giving birth, what are some other risk factors? Age,
older women, and after going through menopause, smoking history, and weight, and whether or not they have pelvic organ prolapse. Those are some of the most common risk factors for having the condition.
Now, you could take the history, and she said, I lose urine when I, cough, sneeze, laugh, exercise?
So typically that you leak with coughing, laughing, sneezing, bending, lifting, exercise, and sometimes even with intimacy.
Is that enough for you to know what the problem is and proceed with treatment, or are there other diagnostic tests that you do?
So usually it's pretty straightforward from the history. The other really useful tool we use is something quite simple, is a voiding diary. The patient writes down how much she drinks, how often she goes to the restroom, and whether or not she has an accident before she gets there. And it's important to really sort out the different types of incontinence. What we're talking about now is stress incontinence or leakage related to physical activities. But it's quite common that women have more than one reasons for her leakage. Sometimes they can have urgency incontinence or overactive bladder. And that's when they have that sudden desire or sudden urge to urinate that tends to be uncomfortable, and before they can quite make it to the bathroom, they have an accident. And it's quite important to distinguish into different types, because how we treat them is really quite different.
Okay, there's multiple kinds of treatment, including one I'm really excited to learn about, a surgical option. But before you get to surgery, what are some other options?
So assuming that the patient primarily has stress predominant or stress pure incontinence, there is a number of treatment options, including physical therapy, weight loss if the woman is overweight or obese.
No, I'm sorry to interrupt. Physical therapy, you mean like Kegel exercises or what?
I'm so glad you asked about that. Another thing that I wish I got a couple bucks for every time I heard that is a woman who tells me, I've been doing Kegel exercises since I did my birthing class, And then you do a pelvic exam and you find that she's squeezing every single muscle in her lower body, but not the pelvic floor. So to think you're doing Kegel exercises and to actually be doing Kegel exercises sometimes can be distinct things.
So that's one thing a therapist can help you with.
Exactly. So
okay.
our physical therapist colleagues are super important in helping the woman find the right muscles and really engage that appropriately so she can have the maximum benefit from the intervention.
And what is bladder training?
So bladder training is more of a treatment we do for urgency incontinence. That can be a retraining of the bladder so you can better deal with those sudden urgency sensations, because I call it the penguin dance to the bathroom. It's actually the wrong thing that the patient can do. And again, if she has good pelvic floor strength, she can learn how to do urge suppression, which is squeeze and relax, and calm the urgency and make it to the restroom. But again, that involves physical therapy and education so she can do the engagement of the pelvic floor at the right time.
All right, let's talk about surgical options, because I didn't even know there was such a thing.
So so let me back up a little bit before talking about surgical options, because I think stress incontinence has a huge gamut of symptoms and bother. So when we do survey studies, it's quite common that adult women have some amount of leakage, but that happens commonly sporadic. I would say for most of those patients who have such rare episodes, we probably don't need to do anything. Now, fast forward to women who now have it frequently or bothersome, or precluding them from doing their normal physical activity. So clearly now it's bothersome. They've come and met with a provider. We tried a non-surgical option, and they're still having bothersome symptoms. Now I think it's really time to talk about how to proceed. And in terms of surgery, there are both non-mesh and mesh type of procedures. The thing to understand is that the mesh-based procedures are the most minimally invasive. If that's the only problem, it's an outpatient procedure with fairly high success rates. 80 to 85% of the women are either completely dry or significantly improved. And overall is fairly safe and effective, with less than 5% of the women incurring complication from surgery that requires another intervention.
And what do you do with this mesh? How does this work?
So essentially, we make a small incision underneath the urethra tube through the vagina, 2 small incisions in the pubic hair area, and we use trocar, looks like a crochet needle, that we pass from the vaginal side to the abdominal side, and we put this mesh material underneath the urethra. And what that does is it provides a support. So when there's periods of increased abdominal pressure, the pelvic floor muscles can work in conjunction with that stabilized floor of the urethra to coapt it shut. So then intraurethral pressure is high and she doesn't leak.
I thought there were a lot of problems with mesh.
I'm glad you asked about that.
That is why he's here.
There's been a significant amount of confusion, I think, with all that's going on with both the Food and Drug Administration's warning regarding transvaginal mesh for prolapse. And that's the key factor. That's just transvaginal mesh for prolapse reconstruction.
Prolapse of the
vaginal walls. Okay?
Because something completely different.
It's a much larger piece of mesh, okay, that's used for a completely different indication that's meant to correct prolapse. The FDA was very explicit that this did not apply for sling procedures for stress incontinence or an abdominal procedure called a sacrocolpopexy to, again, treat pelvic organ prolapse.
Is that because it's a smaller piece of mesh?
That's a very good question. The key, how to best answer this? There's many different variables. So the size of the mesh, okay? Who implanted the mesh and what was she or his surgical experience? And the type of material you used during that original implantation are big, significant variables that can explain the differences in outcomes with those vaginal mesh procedures for prolapse versus stress incontinence. Actually, the treatment of stress incontinence with those polypropylene macroporous mesh has actually been one of the most studied procedures in gynecology. And like I mentioned, overall, it's safe and effective. But even in that realm is confusing because there's actually 3 different types of slings. So I don't know how confusing or in-depth you want me to go, but there's certain nuances even about those procedures.
So there's mesh and non-mesh. So you can actually do this procedure without using mesh. And why don't you do that?
So we used to do that up to the 2000s, and those most common procedures are called a birch or a fascial sling. But both of those procedures require an abdominal incision or a laparotomy. It's much more invasive. And
Laparotomy means opening the abdomen to get this done. But you can do the same thing with the mesh without opening the abdomen.
Yes. We can treat the stress incontinence with a procedure that doesn't involve making an abdominal incision or opening the abdomen.
And the results are good.
The results with the sling are very good.
Mm-hmm.
And compared with both of those procedures, they tend to have women who have the procedures treated with the sling have higher satisfaction and overall lower complications. Because if we back up, what are the 2 main issues with any incontinence surgery? The biggest one is we do things a little too tight, and now she's continent, but she can't empty, okay? And if you do that autologous sling, that open procedure, okay, you don't have
the non-mesh.
The non-mesh, you don't have the mesh-related complications, but your risk of requiring another surgery because it's too tight is much higher. So my point is, if you're going to have surgery for stress incontinence, it's really important to speak with the provider about the risks and benefits of each approach and come up with the risk-benefit scenario that best suits your needs. And that really requires a more in-depth conversation.
And picking an experienced surgeon, also very important. How many of these have you done?
I think our group has done hundreds of these procedures.
All right.
We've
perfect.
been doing those procedures here since 2002.
That's what I like to hear. That's the guy I want doing mine, or yours.
Thank you.
Stress urinary incontinence, a common problem, particularly among women, and it's especially common in women who have delivered their babies vaginally, not by C-section. Several options available to treat them. Dr. Trabuco has outlined Dr. Trabuco has outlined those for us. In severe cases, surgery may be the answer, and the sling procedure with mesh is not only highly successful, but has relatively few complications.
That is correct.
Dr. Emanuel Trabuco, thanks so much for being with us.
Pleasure being with you guys.